Welcome back to Diabetic Foot Files, where we expose the hidden truth behind wounds, limbs, and the systems that fail them. So, we're going to talk about a concept that honestly I didn't even learn that much about, especially when it comes to wound care, but not a lot of people talk enough about. So, what if I told you that some diabetic patients aren't just dealing with high blood sugar, right? High sugar, they're actually walking around with their blood being too thick to heal them as well. So, this is what happens when the blood volume drops, but everything stays concentrated. This is why it can lead to clots, poor perfusion, delayed wound healing, and increased amputation risk. And it's called hemoconcentration. So, what is the concept of hemoconcentration? And it's thick blood, thin margins, right? So, hemoconcentration, I'm going to make it simple. The blood. The blood is made up of plasma, which is fluid, red blood cells, white blood cells, and platelets. So the plasma, which is the fluid, that is about 55% of our blood volume. So more than half of our blood volume. That's mostly water, electrolytes, and proteins, aka like albumin and clotting factors. This is what carries the nutrients and the hormones and waste. Okay. Now, the cellular components, which are the red blood cells, which carry our oxygen via hemoglobin, our white blood cells, which are our immune defense, and remember that also is compromised in diabetes, and then our platelets, which help form clot formation. Now, imagine this: remove the fluid, but keep everything else the same: the red blood cells, the white blood cells, and the platelets. Okay, what happens? Everything becomes concentrated, aka hemoconcentration. So the thicker the blood, right, the harder it is to move. So, like I said, the key concept of hemoconcentration, you're removing the plasma, the fluid, right? But you keep the red blood cells, the white blood cells, the platelets are all the same, and it becomes concentrated. So, what changes? Your blood becomes thicker, so aka increased in viscosity. The cells become more crowded, and the flow becomes sluggish, especially in microcirculation. And remember, microvascular disease is something that affects a lot of diabetic patients. So, an analogy is thinking water versus syrup. One flows easily, one struggles through narrow passages. Now, imagine that syrup trying to pass through a diseased diabetic artery, a microvascular network, inflamed tissue beds. That's hemoconcentration inside a diabetic foot. So, what is the normal viscosity of blood? Normal blood viscosity is about 3 to 4 times thicker than water. So it's tightly regulated because if it's too thin, you're at a bleeding risk. If it's too thick, you're at clotting risk and poor perfusion. So, why does diabetes kind of create a perfect storm for this? So, reduced perfusion. The thicker the blood, the harder it is to push through the capillaries as well as ischemic tissue like a diabetic foot. So, oxygen delivery drops. Remember, oxygen is our healing currency and wound healing slows down. And then something happens called a prothrombotic state. So in hemoconcentration contributes to increased platelet interaction as well as increased clotting factors concentration that directly could lead to a deep vein thrombosis as well as a pulmonary embolism. Another thing that happens is chronic dehydration. So if you introduce hyperglycemia, the mechanism is the glucose spills into the urine, okay? Because there's so much glucose in your blood, right? And it pulls water with it via osmotic diuresis. So you're peeing out their hydration. They're peeing out their hydration. And remember, in old school, before they could test for diabetes, the doctors, and God bless their soul, used to drink the people pee, like taste it, right? To taste if it was sweet, right? Because that's how they were able to tell that they had diabetes. Now, neuropathy. Because neuropathy reduces our protective sensation awareness, patients won't feel the pain, the thirst, or the early signs. And as we all know, the infection risk burden is extremely high in a diabetic foot, especially, if you have a fever, you're having fluid loss. If you have inflammation, there's vascular dysfunction. So the increased infection risk, this is where, even though you have more white blood cells, they can't reach the wound effectively. Why? Because of the sluggish flow and the microvascular dysfunction that is already present in diabetics. So your immune cells are present, but they are functionally ineffective. Now, certain medications. Remember, a lot of diabetics have that triad, right? So a lot of diabetics do have hypertension as well. So they're on things like diuretics or blood pressure medication. They can also cause hemoconcentration. So diuretics, which, a big one in our patients, things like furosemide, hydrochlorothiazide, or spirolactone, right? The mechanisms of these diuretics are to increase your urine output, remove the plasma volume, and leave cellular components behind, and the blood becomes concentrated. Blood pressure medications, some blood pressure medications contribute to hemo concentration as well. So diuretic-based antihypertensive drugs have the same mechanism, volume depletion. ACE inhibitors like lisinopril or losartan, like ARPs, these don't directly cause hemoconcentration, but they can reduce your renal perfusion pressure, which can contribute to a pre-renal state if dehydrated. And then immobility, like we tied back to our previous episode about P and immobility, can boost offloading red rest. Now you have thick blood, and the thick blood is in movement. So, what is the physiology behind it? So, I'm gonna break it down step by step. The plasma volume drops, your hematocrit rises, your blood thickens, the flow slows down, oxygen delivery drops. Okay, so our tissue perfusion is everything when it comes to wound healing. That's why we love me some vascular, right? So without that tissue perfusion, there's no oxygen, there's no nutrient, there is no immune response. And what is the result of that? Delayed healing, tissue necrosis, and infection progression. Now, sometimes it always comes back to a Burkle's triad. The Burkle's triad, which is stasis, hypercoagulability, and endothelial injury. So the stasis is immobility, the hypercoagulability is hemoconcentration. The endothelial injury is diabetes. So hemoconcentration doesn't just slow healing, it fuels clots formations, okay? So that introduces, like I said, the risk of having a deep vein thrombosis or pulmonary embolism. So the same patient with a non-healing ulcer is also the same patient at risk of a fatal embolism. So how do we identify hemoconcentration? Labs see labs, okay? Like an elevated hematocrit. So normal hematocrit in women are like 36 to 46%. In men is 41 to 53%, okay? So elevated hematocrit means increased percentage of the red blood cell volume, okay? Now, also, which will labs will show us that there's hemoconcentration present, elevated hemoglobin. So normal hemoglobin in women are 12 to 16 grams per deciliter. Men is 13 to 17.5, 13.5 to 7.5 grams per deciliter. So in hemoconcentration, the hemoglobin is elevated. Another lab that is elevated that consistent with hemoconcentration is your increased BUN and creatinine ratio. Okay, creatine ratio. So your BUN is your blood urine nitrogen. Okay, so the normal ratio is 10 to 1. Okay, to 20 to 1. But in concentration, the BUN, your blood urine nitrogen, is increased. Your creatinine is normal or slightly increased, and the ratio is greater than 20 to 1. And this is a classic state of pre-renal azotemia. I'm going to just spell it Azotemia. Pre-renal azotemia is one of those concepts that are complicated but actually very logical once you see the flow of it. So, what is pre-renal azotemia? This is a condition where your kidneys are not getting enough blood flow. So, the waste products like urea are building up in your blood. The kidneys themselves are still structurally normal before, you know, that's why it's called pre, before the kidney, right? So, what causes things like that? Pre-renal azotemia. Anything that reduces your blood flow or circulation to the kidneys, like dehydration, blood loss, heart failure, sepsis, diuretics, which are very relevant to our patients. So, patients like on furosemide loses fluid, blood volume drops, and then the kidneys get less perfusion. Physiologically, what's happening? There's a decrease in blood volume, there's a decrease in perfusion, kidneys sense low flow, your body activates the survival mode that retains the water, retains the sodium, and then your kidneys reabsorb the urea to conserve the volume. And the key result will be an increased blood urea nitrogen, okay, and your creatinine slightly elevated or normal, okay? And that's why it creates this greater than 20-to-1 ratio with your BUN and CR, okay? Which is a hallmark pre-renal azotemia. So why does BUN rise more than the creatinine? Urea is reabsorbed when the kidneys try to save try to save water. Creatine is not reabsorbed much, so that's why the BUN shoots up and the creatine lags behind. Okay, I'm pretty sure I'm not pronouncing that correctly, but let me just spell it: CreatiNine, creatine. Okay, so the link to hemoconcentration, like I said, pre-renal azotemia often happens with hemoconcentration because the fluid loss causes a plasma decrease. The blood becomes concentrated and the kidney perfusion drops. And what you will see is a high hematocrit, a high hemoglobin, and a high BUN/CR ratio. Okay. And this matters in our patients who have diabetic feet because they often have diuretics, they get infections easily, poor oral intake, and chronic illness. And they can develop mild dehydration, hemoconcentration, like I said, or pre-renal azotemia. And the consequences of this is poor tissue perfusion, which will result in our wounds not healing, reduce immune delivery, which will increase our infection risk, right? Our infection worsens and increase our clot risk, our DVT and PE risk. So, what are some clinical clues of that? A patient with a normal or high hemoglobin, elevated BUN or CR ratio, or dry mucous membranes or low intake. Okay. So, maybe actually the volume's depleted and poorly perfused, but not healthy. And the most important takeaway of this, when I'm just going like deep diving into pre-renal azotemia, is pre-renal azotemia is reversible if you catch it early. You give the patient fluids, perfusion improves, the labs normalize, okay? But if it's ignored, it can progress into acute tubular necrosis, which is actual kidney damage. So, pre-renal azotemia, the kidneys are starving for blood, but they're not broken. And some signs are like dry mouth, fatigue, tachycardia, low urine output, okay? And in diabetics, these signs are not are often subtle, but, and it can be dismissed very easily. So, how do we deal with prevention and management? So, hydration protocols. Schedule hydration, not drink, not the whole drink when you're thirsty thing, hydration protocols, okay? But this is also like internal medicine category, right? Or your endocrinologist category. Glucose control, reduce osmotic fluid loss, early mobility. Like we said, even with offloading, we cannot encourage a sedentary lifestyle, seated exercises, range of motion exercises, get that calf pump working, leg elevation cycles, and then risk stratification. Identify our high risk patients who are high risk of infection, immobilization, as well as the elderly, because we have to risk stratify their clot risk, right? And then hospital intervention if the patient needs IV fluids or monitoring of their labs, and anticoagulation, that's vascular category, in my opinion, if the clot risk is high. So let's do a quick case story. Let me tell you about patient, 60-year-old male, plantar diabetic ulcer, mild infection, poor oral intake, placed in the CAN boot. What's happening? The healing is stalled, become lethargic, develop leg swelling. Definitely, if it's unilateral leg swelling, definitely got to look. Rule out DVT, right? What's our gold standard? Should know. But, it was a DVT that was almost going to progress into a PE. So the breakdown was that the dehydration was ignored, the hemoconcentration was missed, and the mobilization was underestimated. Okay, so the wound did not fail first; the physiology did. So, what are the key takeaways from this episode? Hemoconcentration is common. It's actually underdiagnosed. It directly impacts the patient, the diabetic wound healing, clot risk, and outcomes because if the blood can't flow, the wound can't heal. Okay? So a normal or high hemoglobin in a diabetic patient does not mean that they're well oxygenated. It may mean they're dehydrated, and poorly perfused. So, hemoconcentration is not just a lab abnormality, it's a hidden driver of poor wound healing, infection progression, and thrombotic risk. In our diabetic foot care, we obsess over the wound, but the real story is it's often in the blood. So, lessen the risk, improve the flow. That's why we love me some vascular. You can't have me go I will be on that hill, okay? I'm not even gonna die on the hill. I'm gonna be on that hill, vascular, vascular, vascular. Saves the limb and life. And this is Diabetic Foot Files with Dr. G, and take care of your feet because they take care of you.